Most people believe a heart attack arrives without warning. One moment everything is fine, the next moment crushing chest pain, an ambulance, an emergency room. That image, the sudden dramatic cardiac event, is the one most of us carry. And it is incomplete in a way that may be costing lives every single day, because the research tells a different story. In a landmark study published by the American Heart Association tracking over 500 patients who had experienced a heart attack, 50% of the men and over 70% of the women reported experiencing clear, recognizable warning symptoms in the weeks, sometimes the full month, before their cardiac event. Symptoms they noticed, symptoms they discussed with family members, symptoms they ultimately dismissed, rationalized, or waited too long to act on. The symptoms were not subtle in the sense of being barely noticeable. They were subtle in the sense of being unfamiliar. They did not feel like what people expected a heart problem to feel like. They felt like fatigue, like indigestion, like a shoulder that needed stretching, and so they were ignored until they could no longer be. Today, I am going to walk you through the 5 most clinically significant pre-infarction warning signs, the symptoms that appear in the weeks before a heart attack, what is actually happening inside the coronary arteries during that window, why these symptoms feel the way they do, and what you must do if you recognize them. Because that window, those days and weeks, is not a waiting period. It is an intervention window, and using it correctly can change everything. I am Dr. Wells, and this is WellAge Health, honest, evidence-based health information for adults over 55 every single week. Before we begin, if you are experiencing any of the symptoms I described today right now, or if you have experienced them recently, please do not finish this video before calling your doctor. The information I am sharing is meant to help you recognize and act on warning signs, not to delay that action while you gather more information. The most important message of this entire video is that early evaluation saves lives. Let's start with what is actually happening inside your coronary arteries in the weeks before a heart attack, because understanding the mechanism changes how you interpret every symptom that follows. Your coronary arteries, the vessels that supply oxygenated blood to the heart muscle itself, are not simply pipes that either work or do not work. They are living structures with walls that accumulate fatty deposits called atherosclerotic plaques over decades. These plaques narrow the interior of the artery, restricting blood flow, but narrowing alone does not usually cause a heart attack. The heart muscle is remarkably adaptable. Coronary arteries can be narrowed by 50, 60, even 70% before the heart muscle begins to experience significant oxygen deprivation during ordinary activity. A heart attack typically occurs when a plaque ruptures. The soft, lipid-rich interior of an unstable plaque breaks through its fibrous cap, like the inside of a blister breaking through the skin, and the immune system responds by sending platelets to seal the rupture. This platelet aggregation, combined with the inflammatory response to the ruptured plaque, rapidly forms a clot inside the artery. If that clot completely blocks blood flow, the section of heart muscle downstream loses its oxygen supply and begins to die within minutes. That is a heart attack. But here is what the research on pre-infarction symptoms reveals. In most cases, the hours and weeks before a complete blockage are marked by a series of partial, temporary events. The unstable plaque ruptures partially. A clot begins to form but does not fully occlude the artery. Blood flow is temporarily reduced, enough for the heart muscle to register oxygen deprivation, and then partially restored as the clot is dissolved by the body's own clot-dissolving systems. This cycle of partial rupture, partial clotting, partial resolution can repeat multiple times in the weeks before the final, complete event. Each of these partial events produces symptoms that, when understood in context, are the body's most direct available warning that something serious is occurring in the coronary circulation. The tragedy is not that these symptoms are imperceptible. The tragedy is that they are perceptible, and most people do not know what they are signaling. The first warning sign is unusual fatigue, and I want to be specific about what unusual means because this is where most people get it wrong. Everyone is tired sometimes. The fatigue associated with pre-infarction states is different in character, and the difference matters. Normal fatigue has a clear cause: poor sleep, physical exertion, illness, stress, and it responds to rest. The fatigue I am describing appears without a clear explanation. It is disproportionate to the activity that preceded it. Simple tasks that were previously effortless, walking up a flight of stairs, carrying groceries, gardening for 30 minutes, produce a degree of exhaustion that feels wrong. It does not fully resolve with rest. It persists day after day. In women specifically, this unexplained fatigue is the most commonly reported pre-infarction symptom, more common than chest pain. The American Heart Association's Go Red for Women research found that over 70% of women who later experienced a heart attack reported unusual fatigue in the weeks preceding it. Many described it as the worst fatigue of their life, appearing without explanation during a period when they were not ill and had not changed their activity level. The physiological mechanism is directly connected to what I described above. When the coronary arteries are experiencing intermittent partial restrictions in blood flow due to the unstable plaque activity occurring in the weeks before a heart attack, the heart muscle is intermittently oxygen deprived. The heart compensates by working harder to maintain output, which is metabolically expensive. The increased cardiac metabolic demand, combined with intermittent hypoperfusion of heart muscle, creates a systemic energy deficit that the body experiences as fatigue. If you or someone you know experiences fatigue that is unexplained, disproportionate, and persistent, particularly if it represents a change from your recent normal, this is a symptom worth taking seriously, not ignoring and hoping it passes, taking seriously today. The second warning sign is chest discomfort that does not match the classic description of a heart attack. When most people think of cardiac chest pain, they think of the dramatic Hollywood version, crushing, severe, radiating down the left arm, accompanied by immediate incapacitation. This presentation does occur, but in the weeks before a heart attack, the discomfort is typically far more subtle, far more easily rationalized, and far more frequently dismissed. It may feel like pressure, like someone is sitting on your chest, not crushing, but present. It may feel like tightness, like a band around the chest that comes and goes. It may feel like a vague heaviness that appears during activity and disappears with rest. It may feel like indigestion, a burning or fullness sensation in the center of the chest that seems to improve with antacids, leading people to attribute it to what they ate rather than to their heart. This last point deserves emphasis. Cardiac discomfort and gastrointestinal discomfort share overlapping nerve pathways in the chest. Both can produce a burning fullness sensation in the same region. Millions of adults have attributed the early warning discomfort of an unstable coronary plaque to acid reflux, taken an antacid, felt temporary relief, and waited weeks before seeking evaluation. The key distinguishing feature of cardiac chest discomfort versus gastrointestinal discomfort is its relationship to physical exertion. Cardiac discomfort from insufficient coronary blood flow, called angina, characteristically appears or worsens with physical activity and improves with rest. Gastrointestinal discomfort is not reliably affected by physical activity. If you notice chest discomfort that reliably appears when you exert yourself and reliably eases when you rest, that pattern is cardiac until proven otherwise and deserves same-day medical evaluation. The third warning sign is shortness of breath. And again, the character of this symptom is what makes it medically significant, not simply its presence. Adults over 55 commonly experience some degree of exertional dyspnea, shortness of breath with activity, from deconditioning, lung changes associated with aging, or other respiratory conditions. What I am describing is different. Pre-infarction shortness of breath appears without a clear respiratory cause. It occurs at activity levels that previously did not produce it. It may appear at rest in more significant cases. It may be accompanied by a sense of air hunger, the feeling that each breath is not fully satisfying, that does not resolve with slow, deep breathing. It sometimes wakes people from sleep. The mechanism connects directly to the heart's function. When the heart muscle is receiving intermittently insufficient blood flow, its ability to pump effectively is transiently reduced. The left ventricle does not empty completely with each contraction. Pressure backs up into the pulmonary circulation, the blood vessels of the lungs. The lungs become slightly congested. The result is reduced gas exchange efficiency, and the symptom is shortness of breath that seems out of proportion to the activity, the environment, or any respiratory explanation. New or worsening shortness of breath in an adult over 55, particularly when it appears alongside any other symptom on this list, is a cardiac symptom until proven otherwise. It warrants evaluation, not monitoring at home to see whether it improves. The fourth warning sign is pain or discomfort in unexpected locations, and this is the warning sign most responsible for delayed treatment because the locations involved do not feel like the heart. The cardiac pain pathways are complex. The heart shares nerve supply with several other structures, which is why cardiac ischemia, insufficient blood flow to the heart muscle, can produce pain perceived not in the chest, but in the jaw, the neck, the left shoulder, the left arm, the upper back between the shoulder blades, or even the upper abdomen. In women, non-chest pain locations are particularly common as the primary presentation of cardiac ischemia. A woman who develops unexplained pain in her jaw or neck and attributes it to a dental problem or a muscle issue. A woman who experiences aching between the shoulder blades and assumes she slept awkwardly. A man who develops left arm discomfort that he attributes to overexertion at the gym. The feature that makes these referred pain patterns significant is their character. They tend to be pressure-like or aching rather than sharp. They may come and go. They may be accompanied by fatigue or vague chest discomfort. And they may worsen with physical activity and ease with rest, following the same exertional pattern that characterizes other forms of cardiac ischemia. Any unexplained pain in the jaw, neck, shoulder, arm, upper back, or upper abdomen, particularly when it appears in combination with any other symptom I am describing, deserves a cardiac evaluation. Not a dental appointment, not a physiotherapy visit, not a week of monitoring, a cardiac evaluation. The fifth warning sign is sleep disturbance, and specifically a pattern that most people would never connect to their heart. In the weeks before a heart attack, many patients report difficulty sleeping that is new in character. Waking frequently, inability to get comfortable, waking with a sense of anxiety or unease that does not have an obvious psychological source, or waking at night with episodes of shortness of breath that resolve when sitting up. This last pattern, waking with shortness of breath that improves when you sit up, is called paroxysmal nocturnal dyspnea, and it is a recognized sign of left ventricular dysfunction. When you lie flat, the distribution of fluid in the body shifts, increasing the blood volume returning to the heart and the lungs. If the left ventricle is not pumping efficiently, because the myocardium is intermittently ischemic due to unstable coronary plaques, this increased preload can push the pulmonary circulation into mild congestion that is experienced as shortness of breath. Sitting up redistributes the fluid, reduces pulmonary venous pressure, and the breathing improves. If this pattern has occurred for you in the past several weeks, waking at night, feeling breathless, sitting up to breathe, then returning to sleep when the sensation eases, this is a symptom that warrants urgent cardiac evaluation. The more general sleep disturbance seen in pre-infarction states, the anxiety, the restlessness, the sense of something being wrong that you cannot articulate, may reflect the autonomic nervous system's response to intermittent cardiac hypoperfusion. The body's threat detection systems are receiving signals from the heart that something is not right. This registers consciously as a vague sense of unease or dread that most people attribute to stress, anxiety, or simply age. Listen to that signal. It is not weakness. It is not anxiety disorder. It is your body's most sophisticated alarm system trying to get your attention. Now let's talk about the critical differences between how heart attacks present in men versus women, because these differences directly affect how pre-infarction warning signs are interpreted and acted upon. Men are more likely to experience the classic presentation, exertional chest pain that is clearly pressure-like, radiating to the left arm, accompanied by sweating and nausea. Women are significantly more likely to experience atypical presentations, the unexplained fatigue, the jaw or back pain, the shortness of breath, the sleep disturbance, without the classic chest pressure pattern. This difference in presentation has historically contributed to delayed diagnosis in women who are more likely to attribute their symptoms to stress, menopause-related changes, or gastrointestinal issues, and who are statistically more likely to be sent home from emergency departments without a cardiac diagnosis during what turns out to be a pre-infarction period. If you are a woman over 55 and you have experienced a new pattern of unexplained fatigue, unusual sleep disturbance, or discomfort in atypical locations over the past several weeks, please advocate clearly and specifically for cardiac evaluation. Ask for an ECG. Ask for troponin levels. Ask whether a stress test or coronary imaging is appropriate. You are not being difficult. You are being medically accurate about your risk. Here is your complete action plan, and this one is more urgent than most I give. Step 1. Know the 5 warning signs. Write them down after this video. Unusual, unexplained fatigue disproportionate to activity. Chest discomfort. Pressure, tightness, heaviness, or burning, particularly with exertion. new shortness of breath at activity levels that previously did not cause it, pain or discomfort in the jaw, neck, shoulder, arm, upper back or upper abdomen, new sleep disturbance with nighttime breathlessness or a persistent sense of unease. Step 2. If you are experiencing any combination of these symptoms right now, call your doctor today. Do not wait until your next scheduled appointment. Call today and describe your symptoms specifically. Use the words, "I am concerned about my heart," because this framing prompts a different and faster clinical response than describing individual symptoms in isolation. Step 3. If you experience chest pain, jaw pain, severe shortness of breath, or sweating alongside any of these symptoms, call emergency services immediately. Do not drive yourself. Do not wait to see if it passes. Call immediately. Step 4. Know your cardiac risk profile. Adults over 55 with high blood pressure, diabetes, high cholesterol, a history of smoking, a family history of early heart disease, or obesity carry significantly elevated baseline coronary risk. If you have 2 or more of these risk factors and have not had a cardiac evaluation in the past 2 years, schedule one proactively, regardless of whether you are experiencing symptoms. A resting ECG, a lipid panel, a fasting blood glucose, and a discussion of your overall cardiovascular risk with your physician is the minimum appropriate baseline for adults over 55 with multiple risk factors. Step 5. Share this information with someone you care about. The person who most needs to see this video is probably not going to find it on their own. A spouse, a parent, a sibling, a friend over 55. The pre-infarction window is only useful if the person in it recognizes what they are experiencing and acts on it. Your sharing this information might be the reason someone uses that window rather than wasting it. The heart gives warnings. Most people do not know what they look like. Now you do, and now you have a responsibility to yourself and to the people in your life who trust you to pass important information along when you have it. Thank you for watching. Please subscribe. I cover topics exactly like this every week. Leave a comment and tell me whether any of the 5 warning signs I described today match something you or someone you know has experienced. I read every single comment.